Welcome to our second installment of podcasts about the Centers for Medicare and Medicaid Services, otherwise known as CMS, and their Hospital Star Ratings program. Last time we heard from Akin Demehin and Gillooley, who lead AHA's work on policy regarding quality of care. CMS had proposed several changes to the star ratings methodology. Since then, the agency has finalized some, but not all, of those changes. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Heddery, Executive Speechwriter for AHA. Today we'll hear about what changed, what didn't, and what still needs to. And we'll get to the perspective of a hospital leader who can tell us how they see the Star Ratings program. Akin and Caitlin, thanks again for being on Advancing Health. Can you give us a quick recap of how the Star Ratings program will now be calculated?
Sure. So the biggest change to the methodology was how the measure group scores, that is, how well a hospital did in each category of measures, is calculated. So before, CMS used a complex statistical technique called latent variable modeling to combine actual performance with assumptions about unobserved dimensions of quality based on available measure data. Now, however, CMS will calculate scores with a simple average. And this is going to make it easier for hospitals to understand how their performance translates into a star rating. And because the process is more consistent and transparent, hospitals can make better predictions for how they'll fare in the program based on their own data. Another major change that was finalized as proposed was collapsing the measure groups from 7 to just 5. CMS consolidated 3 groups into one. Because of various quality reporting program changes across the past few years, each of those groups that have now been consolidated only had a handful of measures, and those measures weren't necessarily related to one another. So, for example, one group, effectiveness of care, assessed both influenza vaccination among personnel as well as patients leaving the emergency department before being seen. Those are really two very different concepts, and they don't give you a great idea of overall effectiveness, especially if a hospital reported just one but not the other. But now that these groups are merged into a single group called timely and effective care, it's less likely that any one group or one measure will have a disproportionate effect on the overall score, especially when you consider some of the other methodology changes that the agency finalized.
And along those same lines of changes, a couple of other big changes that CMS adopted. The first is that they're going to require hospitals to report on a minimum of 3 measures in at least 3 measure groups. And one of those measure groups has to be either mortality or safety. And you have to get a score in the mortality or safety categories to get a star rating. What that means as a practical matter is that every hospital with a star rating will have at least one thing in common now, and that is they will be able to report on either one of those 2 measure groups. Under the prior methodology, a hospital reporting every single measure could be compared to a hospital reporting just a few, or hospitals getting the same rating could actually be assessed on completely different measures. So those 2 hospitals getting a 4-star rating wouldn't necessarily tell you much about the quality of care that they delivered. The other big change, and this is among the most consequential in the star ratings methodology, is the adoption of what's called peer grouping. So what CMS is doing here is placing hospitals into one of 3 peer groups based on the number of measure groups that the hospital reports. One category will consist of facilities that reported all 5 measure groups. Another category will consist of those facilities that report 4 of the 5 measure groups. And then the last one is for those hospitals that can report just 3 measure groups. You know, these changes have a lot to do with CMS trying to create a more usable apples to apples comparison in star ratings. Under the prior methodology, all hospitals were compared directly to one another. And what CMS heard was that given the variety of different kinds of hospitals, different sizes of hospitals, different patient mixes of hospitals, that they needed some way of creating a more comparable approach to star ratings. That's what they attempted to achieve with doing peer groupings.
So it sounds like there were some fundamental adjustments to the underlying methodology. Would you say that these changes have fixed the issues with the star ratings that you talked about on our last podcast?
That's a great question, Tom. And I think it's fair to say that CMS did address some major issues with star ratings, but they certainly did not fix everything. The best example of that was a proposal that they actually chose to walk back in the final rule. And that was a proposal to place hospitals, at least in calculating their readmissions group performance, into peer groups based on the proportion of patients duly eligible for Medicare and Medicaid. This is an approach that's used in the hospital readmissions penalty program and that CMS had proposed to import into star ratings. And it was intended to address a concern that has existed about not just star ratings, but a variety of other CMS quality measurement programs around readmissions performance and performance on other measures being affected by things that are outside of their control in the community. We know that one's propensity to be readmitted has to do not just with the care they get in the hospital, but in their access to the resources that assist with their follow-on care. And that is not equal in all communities. And unfortunately, without any kind of adjustment, CMS is sort of treating hospitals as if it is. So we were disappointed to see CMS not adopt that proposal. We think that star ratings and at least the readmissions measure group really does need to account for the influence of social risk factors on performance. You know, the dual eligibility peer grouping approach isn't a perfect way to do it, but it is something. And it is a strategy that CMS already uses in other programs to account for risk.
CMS also didn't address some of the other longstanding issues with the star ratings in either the proposed or final rule. So methodologically, they still run the K-means clustering that assigns hospitals a number of stars based on their scores, meaning they use another statistical technique to try to get hospitals with the same or close scores, the same star rating. Now, they'll be clustering within the peer groups of the number of measure groups reported, but there will still be somewhat arbitrary cutoffs. Like if one hospital gets a summary score of 99.5, it gets 5 stars, but another gets a score of 99.4 and gets 4 stars. Now, those are made up numbers, but those hospitals, are they really different by a whole star? And are the hospitals in each peer group really comparable? In the rules, CMS admits that almost 3/4 of all the hospitals in the program will be in the same peer group, the one reporting all 5 measure groups. So you'll still be seeing community hospitals compared to large academic medical centers, high volume urban hospitals with smaller critical access hospitals. And this is really more an issue with the star ratings conceptually. There's so much diversity among hospitals in what they look like, their size, the number of beds they have, who they treat, what services they offer, that trying to determine best hospital is like trying to determine best baseball player. Best how? Most home runs, most complete games thrown. You get the idea.
Yeah, that's really an interesting observation, Caitlin, and a good seg. We've talked about what goes into the star ratings, but now let's talk about what we can or can't get out of them. We've brought in Dr. Anthony Weiss, the Chief Medical Officer for Beth Israel Deaconess Medical Center in Boston, to give us some insight into how hospitals and health system leaders and clinicians and patients can use the star ratings. Welcome, Dr. Weiss, and thanks for coming on the podcast today. Can you give us some idea of how the star ratings fit into the overall quality improvement efforts at Beth Israel Deaconess Medical Center?
Great. Thanks for having me here today. Well, the star rating itself does not drive our quality improvement work. The rating is too general and it's too delayed to serve as a meaningful management measure for our work. Knowing that we're a 3-star hospital actually tells us very little from an operational perspective in terms of what our improvement focus should be. And in fact, knowing that data is in some cases 5 years old further compounds the problem because it makes it inactionable for present day process improvement. To follow up on Caitlin's baseball analogy, it would be akin to becoming the GM of the Yankees and being told that they had a 500 team 5 years ago. You'd have no real idea whether changes are still necessary. And if so, what exactly are you going to change? Is it the pitching, the hitting, the base running, etc.? So that said, the individual components of the star rating, and I think there's something like 50 or so measures that make up the rating itself, those individual components are actually valuable and meaningful. They're well vetted, established measures of performance, which we do track and trend in real time to drive our performance improvement efforts. So I guess in that sense, there is some meaningful information in there, but you really need to dig and uncover it and track it in your own way to make it work for actual improvement.
Do patients really use the information from Care Compare to make decisions on where to go?
Well, I'm actually not quite certain. I do worry though that the star rating is misleading to patients for a few reasons. First, it's really a mixture of apples and oranges. For example, our hospital performs extremely well on mortality. Let's say we're a 5-star mortality hospital, but quite poorly on readmissions. So when we combine those two, we're a 3-star hospital. And so to me, this is really hard to make sense of. It's almost, again, I hate to use baseball analogies, but saying that Babe Ruth was a 5-star home run hitter, but a 1-star stolen base runner. So does that mean overall he was just an average baseball player? I don't think anyone would really say that, but that's ultimately what happens with these metrics. I think secondly, the composite measures can give you a fairly good gestalt for performance relative to some high volume, well-reported conditions like heart attacks or pneumonia. So for those areas, I think there's good information in the CMS star ratings and information that's relevant to a large number of Medicare beneficiaries. But they tell you near nothing about the quality of care for many, many, many other conditions. For example, let's say you're seeking care for lupus or skin cancer or a mental health condition. There's actually no measures at all in the star ratings that specifically address those particular health conditions. And so the star rating itself could be misleading in terms of the quality of care that any particular hospital is going to provide for the conditions that you as a patient might be interested in. And then finally, I think Medicare has definitely been interested in developing simplicity of measures, and I think that they've tried to make these as accessible as possible to the beneficiaries who are the target audience. But the simplicity really belies the complexity of healthcare. And in fact, healthcare is extremely complex, and the measurement of healthcare is complex. As we said, there's something like 50 measures in here. Many of those measures are composite measures, meaning that one measure actually contains within it 4, 5, 6, 7 other measures embedded within it. And even those, believe it or not, are also composites. And so that complexity gets lost, and unfortunately, that may end up being misleading at some level.
So it sounds like the bottom line here is that while there's a wealth of information about quality of care that hospitals collect and report, it doesn't necessarily make it easy to click a few links and know the best place to go to get that care. So Tony and Akin and Caitlin, question for all three of you. What's the one thing you would tell a consumer looking at the star ratings on Care Compare?
Well, I would just say that choosing healthcare is a highly personal decision, and where you get that care and with whom. So that each person is going to value things differently. Maybe it's convenience to home, maybe it's being able to get in to see a specialist quickly, maybe it's the latest technology, maybe it's a focus on one of the specific conditions that we talked about earlier. The star ratings can tell you some of those things, but they shouldn't be the only place you go for information.
Caitlin or Akin, some thoughts on that?
I think Dr. Weiss made a really great point earlier that I would double up on. I would tell a patient that measuring quality is really difficult. It's very complex. It doesn't mean we shouldn't do it or that we should give up because it's hard or because the methodology isn't perfect. It's a well-known management adage that you can't improve what you don't measure. But at the same time, We and CMS, of course, should continue to hone the process of evaluating quality so that we can get as clear and as accurate and as usable a picture that we can so that hospitals can pinpoint what works and what doesn't and work towards achieving the best care possible.
We spend a lot of time talking about star ratings because they figure so prominently into CMS's measurement programs. There are a lot of other programs in play here, not just ones from CMS, but also dozens of projects to improve quality that take place at the local, state, and national level. Some of these are aimed at improving care for specific procedures in specific service lines and in specific kinds of healthcare facilities. And we know that private payers are also involved in a number of quality improvement and assessment programs. So it's important to know that there is a lot more to quality measurement and creating that picture of quality for patients than just star ratings.
It's encouraging to hear that so much work is being done behind the scenes to get clinical care right. I know this is a never-ending crusade undertaken by each and every person who works for a hospital and health system. And here at AHA, we'll continue to work with CMS to refine how they evaluate quality. Keep an eye out for more materials and further podcasts, we hope, on this important effort. This has been Advancing Health, a podcast from the American Hospital Association. Thanks for listening.